To conclude our panel before our open discussion, one of our own Archdiocesan priests, Father McLean Cummings. Father Cummings is a Chicago native, earned his bachelor's degree in philosophy from Harvard University. He attended Maria Mater Ecclesiae in Rome and finished his last year of theology at Mount St. Mary's here in our Archdiocese. Ordained to the priesthood in 1998. His pastoral experiences include working for the Archbishop of Moscow with the Missionaries of Charity throughout Europe. He's currently a parochial vicar at Our Lady of Perpetual Help in Ellicott City, and he's involved in formation, advising, and spiritual direction of seminarians at Mount St. Mary's Seminary. We welcome him. We're grateful he's here.
I'm very happy to be here. It's really an honor to be with such an esteemed panel, and thank you, Archbishop, for including me, and the organizers as well. The title to my contribution was Healthcare Reform Too Much of a Good Thing, which I hoped would sort of indicate that I was hoping that you would be willing to think outside the box a little bit. Normally we think of healthcare as a good thing, but any medicine, as we know, if you take too much of it, can be a bad thing. So a little maybe thought experiment with healthcare, which began, as the Archbishop noted, when I was in Russia, St. Petersburg, Russia. I was providing pastoral care for a home run by Catholic sisters, a nursing home. And they came to me for advice with the following matter. One of their employees, a much-loved man in his 60s, had a heart condition that was likely to lead to his demise in a short time. And apparently there was an experimental drug in Switzerland that offered some hope of a significantly longer lifespan. And the sisters were inquiring whether I thought there was any chance of raising the $10,000 that would be required to begin the treatment. So it was a difficult quandary for me. And it was the first time that I, as an American, had ever been confronted with the uncomfortable reality that modern medicine forces us to face. A person's health, and even life, must be weighed against money. We must ask what seems to be an absurd question. If the value of the human person is infinite, what finite sum is his life worth to us? Is it, as this case suggests, as little as $10,000? And if the question is accepted as legitimate, or at least as unavoidable, then how does one answer it? And who answers it? Doctors, bureaucrats, the market, moral theologians? This is, in the main, I think, a new problem. Certainly, in the not-so-very distant old days, a man of means could afford to call down specialists from the big city. He could afford to travel to a warm place, to take the waters. He could, above all, afford to rest, stay warm, well-fed, while poorer folk died younger for lack of such things. Nonetheless, for the most part, treatments were not expensive. Society in general, and no individual in particular, ever regularly spent 15% or more of his income on health care. Most of the health care reform debate focuses on who pays. Given the extraordinarily high cost of health care, the question becomes, how do we spread the risk? Shall it be through purchases from private insurers, mandated or voluntary? Or should it be from payroll taxes and public insurance? The question of why these expenditures are so high is indeed part of the debate, but a small part. There is, to be sure, a concern to make high cost more manageable, yet still most everyone accepts that it must be a high cost. For instance, there are calls for less waste, more competition, tort reform, and so forth. Nonetheless, it would seem that these debates are often technical, partisan, and missing a bigger question. It's assumed that the high level of health care, the highest level of health care that is technologically possible, is a desideratum, desirable, is attainable, and is even a human right. But is this the case? Presenting the perspective of a moral theologian, I would not presume to trespass into that complex thicket of questions regarding how best to spread the expense of health care, or even how best to reduce those costs to some degree. But it would be, I think, my role to raise uncomfortable questions at the root of why healthcare costs are so high in the first place. What has happened, or better is happening, that a nation should be willing to spend so much money on its physical well-being? Is it right that one nation's citizens should spend so much on their health while other peoples in the world can afford so little? How is it that this debate, which is usually conducted without looking beyond our nation's borders, has failed to include the fact that Americans spend twice as much per capita on their health as even Canadians, Swedes, Germans, or Australians? The philosophical and theological perspective is often an unpopular one. The questions that I want to ask are questions that politicians on both sides of the aisle would not consider asking. Indeed, for most Americans, we have gradually grown accustomed to the idea that we deserve the best care that technology can provide and that money can buy. It must be convenient and effective, backed up by studies, controlled by regulations, guaranteed by the threat of lawsuits. We're all supposed to have our own doctor who will respond to our every whim. And most of all, we expect this no matter who we are, at a low cost. The growing expectations, which have much to do with an exaggerated sense of rights, a fear of suffering and death, an almost religious faith in technology, and an understandable wish to have poor Americans share the same benefits, seem to be leading to a genuine crisis. The philosophical and theological perspective should recall us to first principles, which would be genuine wisdom. As the ancients asked in a different context, have we, for the sake of life, ignored the reasons for living? Philosophers and theologians have often been mocked and killed, hopefully not in this case, for their perspective is unpopular. Their contrarian bent would lead them to point out, just as medical science is celebrating a new cure, that the patient will still die in a little while of some other cause, perhaps even a worse one. Now, clearly, there is a great service provided by those who fight against disease, but we mustn't lose sight of the fact that there's also and always an aspect of futility in all that medical science can do. We will all die, and with some degree of suffering. The effort to conquer every kind of human misery needs to be tempered by recalling that it is ultimately a battle that cannot be won. There remains some of the hubris of the followers of Descartes, who thought that the application of reason to human health would enable man soon to live to the age of the patriarchs. The approach of Catholic ethics, on the other hand, is eminently realistic and practical. Not long ago, on the occasion of the 25th annual conference organized by the Pontifical Council for Healthcare Workers, Pope Benedict XVI reiterated the right of every human being to basic health care. But the word basic is very key here. We could say that the point of my remarks today is really to ask, what is basic health care? There must be some care that is not basic and no longer a right. Certainly everyone will agree that much cosmetic surgery should not be covered by public insurance, but the line surely is not to be drawn there. We must ask, if too many people seek an excessive degree of health care, will it be possible to see that all people, or even all Americans, have access to care that is basic? In his speech, the Pope lamented the fact that, quote, still today, many of the world's populations have no access to the resources they need to satisfy their basic needs, particularly with regard to health care, end quote. This is because in some places, he added, quote, we are witnessing an attention to health that borders on pharmacological, medical, and surgical consumerism, almost a cult of the body, end quote. The Holy Father was discreet enough to leave specific countries unnamed. We can find some inspiration for this aspect of Catholic social teaching in that document which has been immortalized as the formal entrance of the magisterium into social doctrine, Rerum Novarum. Although Leo XIII was treating the plight of laborers, whose lot in the Industrial Revolution was little better than slavery, he made some general observations that we could do well to recall in the present context. We find 3 points of great relevance, which reveal the realism of Christian social thought. Pope Leo notes, it must be first of all recognized that the condition of things inherent in human affairs must be borne with. In other words, end quote. In other words, the consequences of original sin, including sickness and death, will always be with us. He continues, quote, in like manner to the burden of work, the other pains and hardships of life will have no end or cessation on earth. For the consequences of sin are bitter and hard to bear, and they must accompany man so long as life lasts. To suffer and to endure, therefore, is the lot of humanity. Let them strive as they may, no strength and no artifice will ever succeed in banishing from human life the ills and troubles which beset it, end quote. The Pope doesn't deny, of course, that Christians should do all they can to alleviate suffering, but such efforts should not become, as they can become, an obsession born of forgetting where our true happiness lies. We cannot imagine that constructing a civilization of justice and love will be the same as building a utopia. The Pope continues, quote, if any there are who pretend differently, who hold out to a hard-pressed people the boon of freedom from pain and trouble, and undisturbed repose and constant enjoyment, they delude the people and impose upon them, and their lying promises will only one day bring forth evils worse than the present. Nothing is more useful than to look upon the world as it really is, and at the same time to seek elsewhere, as we have said, for the solace to its troubles, end quote. Indeed, recalling our theological perspective, it must be pointed out that suffering, pain, and death are not only inevitable, but that they have a positive purpose in restoring man to friendship with God. Every man, whether he recognize it or not, has a vocation to suffer to some degree. The apostles exhorted them to continue in the faith, saying that through many tribulations we must enter the kingdom of God. And our Lord, too, asked, what shall I say? Father, save me from this hour? No, for this purpose I have come to this hour. The very human and Christian desire to alleviate pain must coexist with the equally Christian attitude towards suffering that anticipates it without fear and accepts it without complaint, finding the strength to do so in human virtues elevated by the grace of Jesus Christ. A second point that Leo makes is that this suffering will inevitably be borne in unequal measures. Regarding the inherent inequality of life on earth, he writes, quote, socialists may in that intent do their utmost, but all striving against nature is in vain. There naturally exist among mankind manifold differences of the most important kind. People differ in capacity, skill, health, strength, and unequal fortune is a necessary result of unequal condition, end quote. Some people will always be able to afford the highest standard of care, but this cannot mean that all people can be made able to afford it. This would be naught but a utopian socialist dream. In fact, as a third point, Pope Leo seems content to set at a rather low height the bar delineating when the state should intervene to ameliorate the plight of the poor. He writes, true, if a family finds itself in exceeding distress, utterly deprived of the counsel of friends, and without any prospect of extricating itself, it is right that extreme necessity be met by public aid, since each family is a part of the commonwealth, end quote. Again, we recall our essential question, what is basic health care? To this, everyone has a right, surely every man, woman, and child on the face of the earth. But can basic health care be over $7,000 per person per year? That is what we are spending in the United States, and people are not yet satisfied. Let us remember that about 2.5 billion people in the world survive on a mean income of less than $1,000 a year. Their entire livelihood is 1/7 of our average personal health expenditure, and yet 70% of their income must be spent on food. Even if one is open to the idea, rather radical I think in the context of our healthcare reform debate, that American citizens should get used to the idea of a greatly reduced reliance upon pills, surgery, and doctors, the question will still arise, who should define what constitutes this basic health care? Part of the answer, not the whole, but part, is that the individual would himself decide what degree of health care he really needs, and what is more of a luxury, if the cost of each health care decision were truly linked to his own pocketbook. Let us take an example, which is both extreme and yet all too commonplace, one of my parishioners, a vet, who is extremely unstable walking and must use a wheelchair for most of his excursions outside the home. It's not motorized, but the sort that can be picked up and put into the car. He and his wife wanted a lighter one that the wife could put into the car trunk more easily. He applied for a new wheelchair. He already had one, remember, and was given one that cost, he told me because he was so surprised, $7,000. Of course, he did not pay even 1/10 of that cost himself, and if he had had to, he would have made do without the new chair. We mustn't confuse the reasonable claim that each person should pay for what he needs. We shouldn't confuse the unacceptable notion that we should abandon those who cannot afford what they need with the reasonable claim that each person should pay for what he needs himself. Here we might recall that major principle of Catholic social doctrine, subsidiarity, which is not irrelevant. If a person can take care of himself, he should be left to do so. Otherwise, what begins as welcome help will soon become most unwelcome interference. We easily forget that there are grave, unforeseen consequences to ideas that seem superficially attractive, such as free wheelchairs for vets. While resisting entrance into the concrete details of healthcare reform, for which again I don't feel qualified, I could mention, as an example of such consequences, in the opinion of many, the destruction of the doctor-patient relationship of years gone by. The integrity of the physician-patient relationship is one of the main goals of healthcare reform listed by the Catholic Medical Association. Yet in a piece in the Wall Street Journal entitled "How Medicare Killed the Family Doctor," blame for the fact that patients, it blames the fact that patients who used to pay the bill themselves now no longer care about the cost, with making the primary care doctor a piece rate worker focused on the volume of patients seen every day. The point might be refined, but we must all admit that house calls have ended. In fact, not only the family doctor, but perhaps even Catholic hospital systems are becoming victims of these trends. And there are other unforeseen consequences to excessive health care, which, while less easy to trace and quantify, nonetheless must be recognized. For instance, proper care should enable people to feel more secure as they age. The availability of advanced medical know-how should help them face inevitable disease and death with greater serenity, not less. Yet do we not find most older people living precariously, thinking of their health constantly, and visiting doctors weekly? Some older people are now actually afraid to move in with their children in their declining years because they would feel more secure in an assisted living with a doctor down the hall. To most denizens of the world, we've become a nation of hypochondriacs. Much good, of course, has come from the technological development of healthcare. Do not think I propose to do away with all the advances, which truly are lauded as blessings by the Church, as examples of man answering the noble call to cooperate with the provident and merciful Creator. Nonetheless, it is undoubtedly technology that is a primary cause of rising healthcare costs. It's always a danger of the technological mindset to think that if it can be done, it must be done. And then if it must be done at the drop of a hat by anyone who wishes. Neil Postman, in his 1993 book, Technopoly, provides ample evidence to support the claim that Americans are particularly vulnerable to the siren song of technology. He notes that, quote, although the US and England have equivalent life expectancy rates, American doctors perform 6 times as many cardiac bypass operations per capita as English doctors do. He lists similar facts regarding hysterectomies and prostate surgery before noting that American doctors also prescribe more drugs at higher doses and far more x-rays. Moreover, there is a paradoxical aspect to technology in general. We find that we are busier despite having time-saving devices, and that we communicate less well despite having more means to do so. We should not be surprised if we are less secure in regard to our physical weaknesses despite so many more means to analyze and alleviate them. In the case of medical technology, is it not obvious that as human beings are enabled to live longer, they will have to rely on technology exponentially more, as their frail bodies begin to break down on a variety of fronts. I do not wish to be interpreted as saying that older people deserve less care, just the opposite, as you will see. However, I do wish to perform what George Orwell called the first duty of intelligent men, the restatement of the obvious. In this case, technology cannot bring immortality. the challenges facing medical science only increase with the longevity of the patient. Witness, for instance, the precipitous rise in hip and knee replacements and spinal surgery. As Americans have grown accustomed to solving all of their difficulties with technology, they have begun to distort the very nature of medicine. Contraception is now mandated, part of health insurance in many states. Abortion and artificial reproductive techniques could follow. Such things are far beyond basic health care, and even beyond the medical consumerism and cult of the body decried by Pope Benedict. Such evil uses of medical technology and the claim of a right to have them funded serve to signal the greatest danger lurking in excessive health care. As the population ages, propelled by an exaggerated attention to health, people will nonetheless begin to fall apart. The ultimate impotence of man against death will not go away. People will be more afraid of suffering than ever, as health resources will become increasingly scarce. The temptation to use so-called medicine to cut short the lives that technology can no longer extend will become enormous. It will appear as the only option and as a right. Ironically, the habit of intemperate consumption of health care will lead to a voluntary or even involuntary denial of the very health care, the basic health care, to which all really do have a right. Euthanasia is the deprivation of a patient of basic health care. Healthcare consumerism is producing a crisis which will appear to have no other solution. In this light, perhaps we must welcome the fact that the government is making certain cuts now. Arizona Medicaid has cut funding for some transplants of lungs, hearts, and livers. The FDA has banned Avastin, a cancer drug ostensibly for significant risk to the patient, but more likely for its astronomical price tag, up to $90,000 per year. Such decisions amount to no more than the one that I was asked to make at the nursing home in St. Petersburg, as I mentioned at the outset of this talk. This is perhaps some small step towards a return to an attitude towards healthcare policy that would be genuinely moral. It would be moral and virtuous if it were reasonable. Not every effort to save life or limb is reasonable. Spending hundreds of thousands of dollars to avoid an amputation, for instance, might seem virtuous, but this will be a vice mimicking a virtue, just as prodigality mimics generosity. Such a reasonable, virtuous attitude would, in conclusion, include the following elements. It will first of all seek to provide care that is truly basic and truly universal. If medical care cannot be reasonably extended to all, it cannot be basic. Secondly, more complete kinds of coverage will be dependent, to some degree, on the patient's ability to pay, like education or housing or food, to which all are entitled in some basic degree. One receives better education, housing, or food if one has the ability to pay for it. Such inequalities are not unjust, but natural and inevitable. In the third place, and consequently, it will no longer be seen as a right, or even as a good thing, to eliminate all physical defects, dependency on others, pain, or discomfort. This is part of life. Indeed, it's related to the most beautiful part of life. Charity, compassion, and sacrifice are the best things in life, and we must not view illness and suffering purely as problems to be solved. If we seek to flee from the cross, be we Christians or not, we will have nowhere to go but an ultimately futile flight from reality, ending in a sinful surrender, euthanasia, when technology is of no further avail. The perspective of wisdom, of philosophy and theology, then, is not so complicated, but it is paradoxical. By providing truly basic health care, we will not only be able to care for all men throughout the world, but we will be able to care for the whole man. We are more than our bodies. We have a destiny beyond this life, and paradoxically, if medicine forgets this, it will fail in its noble mission, which is to sustain us on our way there. Thank you.
Thanks for a very healthy dose of wisdom and of Catholic social teaching. And you thought theologians were supposed to give you the answers. A lot of questions, but excellently stated and focused. We do have time for a little discussion now. Our panel is up here, and they have a microphone.
Good afternoon. I want to thank you for some very interesting and challenging words. But to add to the questions, something that the good father brought up and something that the good Dr. Bresci brought up contradict one another in a sense in my mind. Health systems are at an impasse to provide health care to everyone, basic or advanced. And I think no matter what health care system you pick, whether a sort of libertarian one propounded by the Cato Institute years ago, pay as you go, no matter who you are, no matter how much money you have, with or without insurance per se. In that case, who loses out? Those not able to pay, the poor, okay? At another level, you have a system that we have now, a sort of mixed marriage of liberty-based health care versus socialized medicine, whether from the government or through organized health care agencies. In that case, you can ask the question, who loses out there? And as we know today, it's roughly, supposedly 40 to 45 million people who are most likely, of course, the question always is in my mind, who are those people? But likely the working poor. Now, if you go to a purely socialized system, if the British healthcare system, the Canadian healthcare system are of examples to us, then who loses out there? The old and the sick. So my question to any or all of you on the panel is, what is the real answer to that? Who has to or must lose out?
There we go. Needed a mechanic too, besides a moral theologian. I think there is no absolute answer, but the one answer that I think we all sustain, and I tried to mention in what I said, and that is it's a combination. If those of you who, like me, have had parents who have come from Europe or the other parts of the world as immigrants, if you recall their plight in the 30s and 40s, it was such that they would never think of going to the government to get support for their families. They might work 3 jobs, as my father did, but they'd never go out with their hand asking for funds. Now, that is a mindset which has been lost to a great degree, and that's why the church has the issue of subsidiarity. The responsibility primarily is there, but that's not going to solve everybody. There is the poor. There is the people that need support. That's when government should step in. Not for everybody. That's been our position, that we need to do both. We need to care for the destitute and the very poor, but we also need to put the responsibility back to where our forefathers were, and that is self-pride and raising your family yourself.
The nice thing about being an ethicist is we get to evaluate plans, but we don't have to create them. So I don't think I have a solution for you. But for 12 years, I was director of licensing for a state, regulated 65,000 nurses, and their scope of practice and what happens when the underserved, what's the quality of care in services that are being provided where they're not requiring licensed persons, et cetera, which is what happens for populations who are at risk often. The law will change and allow unlicensed care to save money when the government is involved in group homes, et cetera. But one of the things that I think is a significant problem, you raised it with programs like Canada and Great Britain, is that they have a quality-adjusted life year. And a person in a wheelchair is considered to have 25% less quality of life, and therefore the allocation of resources will be less. In our system here, which I as a nurse, I think it's a wonderful system. And one thing that has never been mentioned is tort reform, that the defensive medicine that is costing so much money in terms of unneeded tests for persons, perhaps even over-prescribing, as Father mentioned. And there will be a safety gap, and this hospital is a safety gap. Catholic hospitals, historically, this is 140 years old, this institution, came to serve the immigrants, and there are federal policies and state policies. It's called the disproportionate share hospital that's supposed to be funded for the reading their bleeding. So I guess I'm with Dr. Brescia. It should be a combination, and no one should lose. But I don't think having one public option is the answer because of the dangers we've seen in other countries. But I also think that we can do it better with the system that we have.
I don't think I would add to that.
Excuse me. I think sometimes in your discussion, you made things which were relative into absolutes. For instance, the cost of drugs. Frankly, some of them are obscene. There's a drug that prevents premature labor, which used to be $10 to $15 an injection. Now it's been awarded to one company in Missouri, and they're charging $1,500 per injection. To their credit, ACOG and the American College of Pediatrics has written to them asking to justify this, but not to say, how in the hell do you think you can justify this? But being much more circumspect, I guess, because they have lawyers on all sides. But, these things are ridiculous. There are other things also. When somebody comes in an acute emergency, they all want to live. I've been a doctor too long. It's not a question of, well, I'll reach my time of life and do nothing. Later on, maybe you can just talk about it. But initially, you have to be there for people, okay?
Well, I just wanted to congratulate Father Cummings because I fully agree with the wisdom of his presentation. I'm a graduate in Spain, and I have background, I'm from Mexico, and we have, in quotes, socialized medicine, and I think that the attitude is very different. I have been practicing here for 25 years, and it's very different. Many of my patients, if they really have faith and they know, right now, there is a patient with renal failure, he says, don't put me through dialysis because I don't want it. I will come to haunt you if you do that to me. Says, because my father lived for 3 years in and out of a hospital. What for? Says, the technology in medicine can provide you with a prolonged agony. And I think that after I have made, I fully agree with the ideas that you put so well-rounded. Thank you. It will be good to know if we can get if it's on the website or if we can get it. Because I think, especially for the young doctors, I think it's very important. This is just a change of address when we die. And there is no need for truly. Sometimes just we prolong the agony of the persons. Thank you so much.
First of all, I would like to really thank you, Archbishop, for your leadership and standing for life. I am a nurse who works in a secular hospital, and most of my clinical experience is in intensive care units, where I noticed that slowly but surely we promote a form of euthanasia at the end of their life. So I think I have maybe a tiny bit of a prophetic word to our Catholic Church and our Catholic hospitals. I believe that if we stick to our standards and our beliefs, and we're going to maintain the line of providing for dignity and worth of every human being, I have a feeling that we are going to be extremely successful in the terms of patients wanting to come to Catholic institutions where we can provide life, and as opposed to secular sector, which might be completely taking different turn. So I think there is a hope for our institutions.
Just in the break, I just want to recognize Dr. and Congressman Andy Harris. He had asked the question earlier for his own commitment to health and his own commitment to life as well. Thank you.
I want to make a comment, then ask a question which might be really boring and administrative and asking too much. But I've worked with underserved populations as a family physician for quite a while. And one of the most frustrating things that I've encountered, and Dr. Hill, you alluded to this, is because of the fear of pressure from fellow physicians and also because of malpractice, and which there's no protection if you see someone and they're unable to pay your fee and you don't have the resources. If I don't order that MRI that I know my patient can't afford and that I also know is highly unlikely to be beneficial, I'm very vulnerable. And to the extent we can reform the system and maybe, Father, that aligns with what you were saying, we have these expectations of magic, and it hurts all of us, but it hurts the vulnerable the most, in my experience. The administrative question, I currently work in a federally qualified health center, and trust me, if my centers, like most centers, this is not the way to cost-effective care for everybody. As things are evolving, I'm wondering, my center is trying to evolve a partnership with our local Catholic hospital, and I'm concerned about how feasible this might be for us in a year or two, for federally qualified and then for the look-alike clinics. Thank you.
Thank you to the panel. I certainly.
I think, was that a question?
Yes, if you can foresee the future a little bit.
One of the things we do at the National Catholic Bioethics Center is we do, besides those consultations I mentioned that come in 24/7, we have consultations with healthcare agencies, Catholic healthcare agencies particularly, in terms of their engaging in collaborative ventures, and it is becoming increasingly difficult. And one thing that we advise is that they contact the local bishop early on, even if they're not a diocesan hospital. And often that bishop will contact us, because if we get the document after certain proposal after certain documents, legal documents, have already been signed, it is problematic. And one of the three programs that Attorney Piccirillo mentioned that is highly likely, as he put it, I think it's right in there, but he's the attorney and I'm only a canon lawyer, and he's brilliant. So highly likely that there will be funding is the community health centers. So there was $11 million allocated that doesn't have that cost sharing where you have to write a separate check. It would be a direct pay. So I think your fears are valid. And there have been other initiatives where joint ventures have actually cost lots of money for the Catholic institution when they realized they couldn't do it after they've gone pretty far down the road. So we're not looking for any more business, believe me, we're a not-for-profit, but I think your concerns are valid, and through your bishop and that Catholic agency can always contact us.
Thank you, panel. That was really interesting information you presented, and certainly helped me, I think about some things I hadn't been thinking about. My question, though, is to you, Father. Wonderful presentation. I don't remember you saying, or maybe I missed it, but could you share with us what you decided to do with that $10,000 question?
No, I suggested to them that it wasn't worth pursuing. That even just practically, it would be impossible to find someone to provide it. just on the side, it really opened up my thinking a lot about healthcare. Being over there, seeing Russian hospitals, the lifespan for a man in Russia now is 59 lifespan. It's gone down since the Soviet times, dramatically.
You know, the need.
Yes, did we have, Chuck, did you have?
First of all, thank you, panelists, for the great discussion and the thought process. I'm not a physician or a registered nurse. I'm less familiar with medical care, and that qualifies me to be on a board. So my question is maybe beyond the scope of the presentation today, but it was mentioned about affordable health care. And my concern is an element that we haven't talked about, and that is the insurance carrier. And that might be beyond the scope of any of the organizations, but the cost of insurance is driving health costs way up, and has nothing to do with the reimbursements coming to the providers, the hospitals, or the physicians, reimbursement for drugs, prostheses, and the like. We have a provider of the insurer of last resort in Maryland called Blue Cross Blue Shield that tried to convert to a profit operation a few years ago, and that was defeated by the legislature. And I'm not sure how much oversight there is anymore by the legislature. I understand that the profits are rather significant these days. And I'm not one for oversight, government interference, or any other. We have enough regulation within healthcare, enough oversight, audits, and that type thing, looking at the hospitals and the individual providers. But I'm wondering what, if anything, we're doing. This is my question: is there anything we're doing in regard to how we hold down and control those insurance costs? Is it totally out of our realm that anything can be done to help the individual to have affordable insurance?
Again, we have a multifaceted reason for the rising insurance. Number one, it's what Father was addressing in his talk, and that is the expectation of the American people for health care. And you want to have the best, and you want to have it now. You don't want to wait 6 months for your hip repair. You don't want to wait a year for your heart catheterization. You want it now. This means it puts a stress on the providers to have that available 24/7 in some instances. The second thing is that you go, any patient presenting to the emergency room with a condition that in the years gone by, the physician's expertise and acumen was used alone to make the diagnosis, and if it didn't work or it wasn't better, it came back. This time, if that doesn't work, you end up in court. And so therefore, you have to deal with the fact that you've got to do things because otherwise you're legally liable, and you can't afford to stay in practice as a physician. So that's two factors. But I think the biggest thing would be if our society here in the United States began to think about what Father said about health care, that we can't have everything all the time. And you've got to be willing to go along with your physicians. And I think a lot of physicians would do that. But they're afraid to do that because they may end up on the short end of a lawsuit.
Thank you. Yes, ma'am. Way back.
Hi, I have a question, and I guess I'd like the Archbishop to clarify this a little bit. Two of our speakers, Dr. Bresci and Father, you mentioned the subsidiarity concept, and my question is, why would we be opposed to a provision in the law that says everybody has to pay something for insurance? And I guess my perspective on this is from two different points. I've been a nurse for 30 years, mostly in critical care and some in ER settings, where I've had people come in and say, well, I don't have to take care of myself. If this doesn't work, I'll just come back. It's free. I don't have to pay for this. 5 years ago, I went through cancer treatment, and I ended up with $100,000 of medical debt, even though I've got insurance for some of the reasons that we've talked about. Chemotherapy bill was $22,000 per month. My insurance paid 75%. You can do the math. Okay, nobody can afford that. So getting sick with something like cancer, you can wind up bankrupt very quickly. And I pay for my insurance. I'm responsible, I pay my bill. But then I'm taking care of people who come in and say, I don't have to pay for this, it's free. So why, as a society, would we not support a provision that says, okay, you can't afford, to pay for every treatment known to man, but you have to pay something so that you are contributing to your own cost?
I certainly don't think that in the issue of subsidiarity that we would not support that and have supported. The church supports that. I would mention that. But I think that, again, you have to watch out, as Father had mentioned, and also Dr. Hilliard, about the advances of medical science in this country. We have everything that any country has and more. And we're leaders, and that's why people come to this country and could afford it. They come here for their treatments. However, we have to have our own organization of physicians and scientists come to the same idea that just because they found a new molecule that might do something a little better, that they ought to use this in treatment. And knowing that the next thing is, what's the price tag? Well, the price tag is insurmountable for many people. So we have to come to the realization and say, wait a minute, Mr. Professor, so we have this and that, and it's doing a good job. It's not going to be 100%, but as Father said, there's nothing that's 100%. So we have to begin to realize it, but see, we don't think that way because we're always looking for the best and the latest, but it's also the costliest.
Yep, the only thing that I was thinking regarding mandatory insurance is that obviously, well, not obviously, because I think it's contested, but it could be that the price of everyone else's insurance goes up, or in some way a cost is laid on the rest of society for those who aren't insured, and that would be certainly not against subsidiarity to say, well, you have to carry your own load in that degree.
I think we're far away from a consensus that we realize in this room. There's kind of a consensus, but I think our culture is far, far from what we're saying. And how long it's going to take to get us back to some solid thinking and responsible philosophizing, I have no idea. I don't know. Yes, ma'am.
Hi, I'm a retired nurse, but I worked in a nursing home 2 evenings a week. I worked last night. Out of 30 patients, 5 of them were on long feeding tubes. That's where the money goes. I mean, they're kept alive. They're like zombies, just laying there year after year. And it's so sore distressing, as a Christian, to try to see Christ in your patients, and you do the right thing, and it's a challenge, I'll tell you that. And thank you very much. Wonderful discussion.
I'd just like to, if I can, respond to that. When I was working my way through school, I did work in 2 long-term skilled nursing facilities, but basic nutrition and hydration, even assisted nutrition and hydration, is basic care if persons can still benefit from it. If we don't have to restrain them because they keep pulling out the tube, or if the site is, I'm not talking about site infections or aspiration, but if they're tolerating it even as they're declining, and if we remove it, the cause of death is going to be dehydration or starvation. To remove those is basically passive euthanasia. So there are times when it's clearly beneficial, and yet there are many times when folks call us and say, is this something that is morally required. And many times the answer would be no, because the patient is now going to die from the underlying pathology before they die of dehydration and starvation. But if it's working and if they're not getting infected, not aspirating, there actually has been a statement from the Congregation for the Doctrine of the Faith that this is considered basic care, because we have now gotten to the point, and it wouldn't be basic care perhaps in a third world country, it would be a disproportionate burden, but in our country, if all is working well, and it is considered basic care. So.
Yes.
Regarding insurance, and Dr. Bresci was saying, about insurance across state lines, but I think I read that that would allow the federal government to use the Interstate Commerce Clause to seize control the way they're trying to do anyway, because it would be then interstate commerce, which comes under the federal government, and that, and it would violate the subsidiarity we're talking about. But my question about subsidiarity is, how about the health savings accounts, where you use your own money to pay for the basic cares between you and your doctor, the government's not involved, and then you get a catastrophic health insurance, and that's where a health insurance company would be involved, and still, it's not the government involved. It's, I'm sure there are places where you need the government involved, maybe for the poor. Maybe the government would have to pay for the health savings account for really, poor people or something. But if anybody has an opinion on that.
I think currently that's probably the best opportunity people have. I think that health savings accounts should be a way for an individual family or a community to fund their own health care and have excessive or critical care insurance only. That's what we do with car insurance now. We buy insurance for accidents. We don't buy insurance for things you pay out of pocket, such as changing your oil. That's the same idea. But you would have to have some way of covering the folks that can't provide for themselves with a health savings account. But I think it is a form of subsidiarity.
Okay, thank you. I'd ask Dr. Diane Barr, who's our Chancellor of the Archdiocese, just to make a brief announcement.
Good afternoon. On behalf of Archbishop, I'd like you to invite you all to an upcoming lecture for legal professionals. You all have made it so wonderful to have it for medical professionals. We are going to start one for legal professionals. It will be held on Tuesday, May 10th, 2011 at Calvert Hall College here in Towson. And our main speaker will be Mr. John Garvey, who you may know is the president of Catholic University of America. He's going to speak on the topic of freedom of religion, the First Amendment, our church, and our ministry, and you may know that he is an expert in the field of religious law. The other speaker will be Mr. David Kinkoff of Gallagher, Avelius & Jones, and he is one of the attorneys on the O'Brien versus City of Baltimore case. So please feel free, it'll be that evening. It's from 6 to 10, and you're all welcome.
Thank you, Dr. Barr. We're concluding now, and I just want to recognize our Catholic hospitals, the 5 Catholic hospitals who have underwritten this gathering once more: St. Joseph's Medical Center, Bon Secours Health System, Good Samaritan Hospital, Mercy Medical Center, and St. Agnes Hospital. I thank them and their leadership and all of the staff on their staffs who've joined us today. Many of you are here from those hospitals. To Suzanne DeCrane, Vice President, whom we heard from before, Sister Helen Amos, Chair of the Board of Trustees at Mercy Medical, Charles Bauman, whom we've heard from just a moment ago from Good Samaritan, Sister Ellen LaCapria, Vice President of Mission Integration, St. Agnes Hospital, Chaplain Ann Hazelwood, Director of Spiritual Care, Matt Lukasiak, Providence Hospital in Washington, Bonnie Phipps, President, CEO of St. Agnes Healthcare, Sister Mary Scopel, Director of Pastoral Care, Bon Secours Hospital, and Dr. Mary Albert Bouchicor, President, Baltimore Guild of the Catholic Medical Association. And I know we're always looking for new membership in the Catholic Medical Association, and Dr. Bouchicor is right here. I think most of you know her. I want to thank also Joanna Coughlin and Linda Brennigan and the volunteers of our Archdiocesan Respect Life Office who organized and staffed this event with the help of Dr. Barr. And we look forward to seeing you next year for another program designed for medical professionals. If you have any thoughts as to what that might be, feel free to step forward to let us know what more you'd like to hear about. And do check our website, the Archdiocese, for further information. I know Joanna Coughlin would like you to, where is Joanna? Would you say a word? She's done so much of this. Give her a hand.
It's all for Archbishop. Thank you, Archbishop. Just a quick reminder, if you want CMEs or CEUs, you were given an evaluation when you came in to get your certificate back at the registration table. Just turn those in. And there's also, like Archbishop mentioned, there's other evaluations in your bag, just asking for suggestions, requests, what you need from us. So please fill them out and leave them at the table or on your chairs, and we'll come get them. Thank you all.
So the Lord be with you. Okay, you remember. All right. May Almighty God bless you, the Father, and the Son, and the Holy Spirit. Amen. And go in peace safely to love and serve the Lord. Thank you all.